Okay, continue describing the slide.
Infiltration of inflammatory cells and congested capillaries.
Okay, there is main prominent is many small congested capillaries are seen along with inflammatory cells. Here you can see this is a blood vessel, this is a blood vessel, these all are blood vessels, and in the lumina of the blood vessel you can see the RBCs, and these are the fibrocollagenous areas along with edema. There is edema also, and these blackish dots like things, these are all inflammatory cells. There is dense infiltrates of the inflammatory cells. So here you can see history is given. A 47-year-old male came with a history of recent cut injury. With a history of recent cut injury. Biopsy is taken from the site after 1 week of the injury. So identify the lesion. After 1 week of the injury, now the recent cut injury which was there, now after 1 week of the injury, it will go towards healing. So for the healing, there will be presence of the granulation tissue, and the picture will be like this. There will be proliferation of the fibroblasts, there will be proliferating capillaries, there will be inflammatory cells. Now towards the 1 week, now the acute acute inflammatory cells will now be slowly replaced by the chronic inflammatory cells and the macrophages, and there will be healing. I hope you know healing by primary intention, healing by secondary intention. Yes? And there are many growth factors which are required during the healing. Fibroblast like growth factor, platelet derived growth factor, and all these things. Kushal Singh Basnet. Kushal Singh Basnet. Kushal. Okay, Nitesh Kumar Das.
Yes, sir.
Nitesh Kumar Das. Okay, can you please revise what happens in the healing by primary intention?
In primary intention, the cut is superficial.
Okay.
Then after cut, the platelet forms plug.
Okay.
And release the growth factors and inflammatory cells, neutrophils come there.
Okay.
Which phagocytes the debris and dead tissue.
Okay.
Within 24 hours.
Okay.
After 48 to 72 hours, the lymphocyte macrophage come at the site of injury and release fibroblast and activate the fibroblast, which then releases collagen.
Okay. Okay, that's fine. That's fine. So in healing by primary intention, will there be fibrosis or not?
No, sir.
So
there is no such big scar, but in secondary Healing by secondary, there is formation of big scar.
Okay, there will be formation of the scar in healing by secondary intention. Okay, so this is a granulation tissue with proliferating capillaries, fibroblast, and there's presence of the inflammatory cells, mostly the chronic inflammatory cells, but it is mixed. Both acute and chronic inflammatory cells are there. Sections of proliferating fibroblasts, thin-walled congested capillaries, and inflammatory cells, mainly the lymphocytes and the plasma cells are there because it is of 1 week duration. If it was of up to 48 hours, then it would be more predominantly, it would be neutrophils or acute inflammatory cells would be there. But it is of 1 week, so lymphocyte and plasma cells or the chronic inflammatory cells are the predominant cells. So this is from the lymph node, Hodgkin lymphoma. Has this been shown to you in the practical classes?
No, sir.
No. Okay.
No,
So
sir.
this we will discuss at last, because this also will come in an exam. If there is no slides, we'll try to keep the slides, and again you have to see. Okay. So we'll discuss this at the end. Is that fine?
Yes, sir.
Okay. So slide number 23. Anyone please describe this? Anyone else? Whoever want to answer this or describe this, please describe.
Sir, we haven't done this DERMOID.
You have not done this?
No, sir.
Okay. Then we'll keep this also for the end. Okay. We'll keep this for the end. And this slide number 24. Have you seen this before?
Yes, sir.
Okay. Then I know that you can describe this. Okay, one of you volunteer. I know that all of you know this. You just hesitate to talk.
So the given slide shows different cells of the blood. You see RBC,
Okay.
and different stages of maturation of neutrophils. Some are band form, some are segmented.
Very good, very good. Okay. So there is more, you are seeing immature WBCs, yes?
Yes, sir.
Or maturing WBCs along with some mature neutrophils. Is that what you are trying to say?
Yes, sir.
Okay. If you see here, I am very happy what you said. You can see RBCs also, you can see WBCs also, and you can see the platelets also. Yes, here you can see these are the platelets, the small tiny fragments. These are the platelets. Whereas these pale things, these are the RBCs, and these large things which you see, these are the WBCs. So these are the cellular elements of the blood. So which you are seeing here in the slide. So this is a peripheral blood smear which is given. So you see in peripheral blood smear, you see the RBCs, WBCs, and the platelets. So here you can see there is a gross increase in the total count of the WBCs. The WBC total count is increased or markedly increased. Here it should be in lakhs. Here also even it should be in thousands or lakhs. Is this clear to you?
Yes, sir.
Okay. Apart from that, these WBCs, which has been increased, these mostly show the immature population of WBCs, ranging from promyelocyte, which is the largest one, to the bands. In between there is metamyelocyte, myelocytes, okay, and there are bands, and you can see here some eosinophils, and I'm sure there should be some basophils also. And I'm not sure if we are seeing, okay, this is one blast. We can see one myeloblast, although clearly a OR is not seen. So what is this? You see, this total count is markedly increased with immature population of WBCs ranging from the promyelocyte, myelocyte, metamyelocyte, bands, and even the mature neutrophils, along with a very small percentage of blast. Okay, let's say 1% or even 2%. So what is this? Anyone? The diagnosis is written here. Are you listening? Sanne Kurmi?
Yes,
Sunny?
sir.
Okay. What do you think this is? The diagnosis is written here. Can you read it out? Can you read this out? What is this?
It's chronic myeloid leukemia.
Okay. What does that mean? Okay, that means you people do not know about chronic myeloid leukemia or chronic myelogenous leukemia, and you need to revise this very thoroughly. This is a chronic myeloid leukemia. Here, a history is given. A middle-aged man presented with massive hepatitis splenomegaly. Chromosomal studies showed presence of Philadelphia chromosome in the immature WBCs. Peripheral blood smear is given, which we have described many times. Identify the hematological condition. This is a chronic myeloid leukemia, and write the two main features of this disease, which we have already discussed. This you have to revise. You are at home, either open the book, which is in your laptop or mobiles, or go through the some internet sites, and then try to learn about chronic myeloid leukemia. I will ask you personally again, one by one. Okay, we'll leave these identification points for now. We have already discussed this. So, slide number 25. Anyone? Try to describe this.
Peripheral smears showing large immature blast cells. Blast.
Very good, very good. These are blast cells. What else? Will you try to describe the blast? How are the blasts seen? Are they smaller in size or larger in size? Do they have a smaller nuclei?
Larger in
Okay, larger. They are very large in
large
size.
cells with large
Okay,
nuclei.
what else?
Presence of ore rods in the cytoplasm of the blast.
Okay, here you can, in the inset, you can see that there is presence of 2 ore rods. So when there is presence of ore rods, which type of blast do you think this is?
Myeloblast.
Myeloblast.
Okay, very good. This is a myeloblast. Okay, so when there is a presence of a myeloblast, this is a acute myeloblastic leukemia. So the main problem is distinguishing between a lymphoblast and a myeloblast. If you can distinguish that it is a myeloblast, it is a acute myeloblastic leukemia. Or if you can distinguish or diagnose that it is a lymphoblast, then it is a acute lymphoblastic leukemia. And the percentage of to call it a acute leukemia, what should be the percentage of the blast?
More than 20%.
More than
Very good.
20%.
Very good, very good. Many of you have told this, which is very correct. More than 20%, either in the peripheral blood smear or in the bone marrow, both. But initially, FAB, according to the FAB classification, it was 30% in the bone marrow. Just keep that in mind. But nowadays, we do not use that criteria. We use the criteria of 20% cutoff, which has been given by the World Health Organization. Is that clear?
Yes, sir.
Okay, so here you can see large immature blasts which have atypical nuclei, and there is a moderate amount of cytoplasm which is more than that what we see in the lymphoblast, and there are many granules, azurophilic granules are there in the cytoplasm, which also is in favor of the myeloblast, and there are multiple punched out or prominent nucleoli are there. Here you can see these are all prominent nucleoli. So this is also in favor of the myeloblast. And the most important thing which is in favor of the myeloblast are this presence of ore rods. So according to the FAB classification, you know what are the classification of the leukemia or AML, acute myeloblastic leukemia? What are the classification according to FAB?
Eight types.
It is classified in 8 types.
I hope you remember those, right? M0 to M7. Okay, what is M3?
Acute promyelocytic.
Okay, acute promyelocytic leukemia according to FAB. So in acute promyelocytics, you can prominently see the ore rods. Maximum number of ore rods are seen in case of AML M3. Just keep that in mind. So there is presence of myeloblast, more than 20% by definition, and presence of ore rods. If you want to write more and define the presence of myeloblast with all the morphology of the myeloblast, you can add up. Okay, we are going to the next slide, 26th slide. Describe this, please.
The section shows the cardiac tissue, and in which there is infiltration of the inflammatory cells.
Okay.
And there is the wavy nature of the muscle structure is muscle fiber is seen.
Okay. You told about the inflammatory cells. So which inflammatory cells are more prominent here?
Neutrophils, sir.
Very good, very good. Because here, let's see the history of 56-year-old chronic smoker. So, a 56-year-old chronic smoker presented to the emergency room with acute severe chest pain, sweating, and hypotension. So, what does this history suggest of 56-year-old chronic smoker? Why is this history of smoking given here? So why has this myocardial infarction happened in this smoker?
Risk factor. It is risk factor.
Okay, so
Cause atherosclerosis.
okay, atherosclerosis. Because of that atherosclerosis, he has been smoking for a long time, and that is causing atherosclerosis. And there can be either the atherosclerosis itself or the secondary changes in the atherosclerosis can cause myocardial infarction. So after he has smoked for many years, he has atherosclerosis, and then now he presented with acute severe chest pain. That means he has now developed myocardial infarction. So what test is done in the above patient in the first 24 hours?
So myocardial enzymes and ECG.
Very good. One ECG is done, but in the laboratory, what is done?
So we check for the enzyme specific to the myocardial tissue.
So what are the name of the enzymes?
Troponin.
Cardiac.
CKMB. Myoglobin.
Okay. One is CKMB. The next is
Troponin.
which subtype of troponin?
Troponin C. Troponin C.
Troponin?
T and I. Troponin T and I. T and I.
Okay, the troponin T and I. Someone was telling C, which is not correct. And what is your diagnosis? So diagnosis you all know, myocardial infarction. Right, two causes for the above condition. So what are the two causes?
Atherosclerosis. Smoking.
Very good. Okay, one is atherosclerosis. Don't write atherosclerosis and smoking because they too suggest the same etiology. And the other is
Thrombosis, embolism.
Thrombosis.
Ventricular aneurysm.
Okay.
Ventricular aneurysm.
Ventricular aneurysm. You have gone too far. Just tell atherosclerosis and thrombosis. This will be enough. All right. Okay, so here you can see there is waviness of the fiber and some of the nucleus has started fading. So this is a coagulative necrosis, which has been seen in the patient with this myocardial infarction. So the section shows myocardial muscle which appear wavy and eosinophilic, and some areas show the presence of coagulative necrosis and hemorrhage, and there is infiltration of neutrophils. Is that okay?
Yes, sir.
Okay, so we'll stop here today. I hope this schwannoma also is not shown to you in the class. Yes.
No, sir.
No, sir.
Okay. Okay. This will also will keep for the end towards the end, which we have not covered in the class. So we'll cover up here. We'll try to cover up, and when you come back to the college, then we'll show you these slides also. So we'll stop here today. We'll hang up. Is there any question about all these slides which we have discussed?
No, sir.
Okay, there are not much slides. In one class, we can finish up these slides. Then we'll go towards hematology. Then next class we'll start with the instruments, and then if possible, then one class will talk about the practical, like you have the hemoglobin estimation and the DLC, what you do. Yes. Yes. What are the practicals do you do in the
So blood group estimation, blood group determination.
Okay. One is blood group estimation.
Hemoglobin determination.
Hemoglobin estimation and
DLC.
DLC, differential leukocyte count. So these three things we will try to do. Mostly theoretical, and if we can demonstrate, we will try to do it. Okay, then we'll hang up if you have any question. And I have told you to study CML because you didn't answer correctly about CML. So next class, in the beginning, we will discuss about CML. All of you study CML and come in the next class on Friday. Okay, thank you.
Thank you, sir.
Okay, and last thing, many of you have told me to upload the slides of these practical classes. I will upload the gross part because we have already finished it, and the slide part after we have finished the next week. I will upload the slide part too. Is that okay? Okay, that should be okay.
Yes, sir.
Okay. Okay, thank you.
मैंने अकेला लेने था बिल्कुल बहुत सारे रहते हैं